Hello everyone, myself Vibhavana Erle. I am going to present a seminar on peptic ulcer, gastric carcinoma and adenocarcinoma of colon. This was the topic allotted for me. Firstly, peptic ulcer. Definition: peptic ulcer disease refers to chronic mucosal ulceration affecting the duodenum or the stomach. Most common sites of peptic ulcer are the first part of the duodenum, gastric antrum, gastroesophageal junction, and surgical stromas. Etiology and the risk factors: Helicobacter pylori infection, cigarette smoking, chronic obstructive pulmonary disease, use of non-steroidal anti-inflammatory drugs, alcoholic cirrhosis, psychological stress, endocrine cell hyperplasia, Zollinger-Ellison syndrome, and viral infection like herpes simplex virus and cytomegaloviruses. Pathogenesis: there is the imbalance between the aggressive factors and the defensive factors which causes the peptic ulcer. The aggressive factors are gastric acid, pepsin, Helicobacter pylori, and the use of non-steroid anti-inflammatory drugs. Defensive factors are mucus bicarbonate barrier, prostaglandins, mucosal blood flow, epithelial regeneration. Here the aggressive factors increase, whereas the defensive factors are reduced. Gross morphology. Location: duodenal ulcers. Usually they are seen in the anterior wall of first part of the duodenum. Gastric ulcers. They are usually seen in the lesser curvature near the antrum. Gross features: peptic ulcers are usually solitary, round to oval in shape, 0.5 to 2 cm in diameter. They have sharply punched out margins. The base is smooth and clean due to peptic digestion. Radiating mucosal folds extend to ulcer edge. Microscopy: we can see four characteristic layers in the peptic ulcer, that is superficial fibrinoid necrotic debris, zone of acute inflammatory cells, that is neutrophils, granulation tissue, and the fibrous scars. In this diagram we can see here the ulcerated mucosa, and beneath that we can see the superficial fibrinoid necrotic debris, and beneath it we can see the zone of acute inflammatory cells or the neutrophils. Beneath that we can see the zone of granulation tissue, and deep to that we can see the zone of fibrous scar. Clinical features: in peptic ulcers we can see epigastric burning pain relieved by the food in case of duodenal ulcers, whereas pain persists by the intake of food in the gastric ulcers. Weight loss is seen in gastric ulcer, and nausea vomiting can be seen. Complications of peptic ulcer: hemorrhage is the most common complication. Perforation can be seen, and the obstruction to the GIT can be seen. Penetration into adjacent organs also can be seen. Next topic is the gastric carcinoma. Definition of gastric carcinoma: malignant epithelial tumors they are the malignant epithelial tumors of the stomach. About 90 to 95% are mostly adenocarcinomas. Risk factors of gastric carcinoma: environmental factors are Helicobacter pylori infections, smoking, nitrosamine intakes, high salt diet, and smoked food, the food which are fried. Pre-malignant conditions: chronic atrophic gastritis, intestinal metaplasia, pernicious anemia, gastric adenoma. The genetic risk factors are CDH1 mutation, familial adenomatous polyposis, and Lynch syndrome. Molecular pathogenesis. It is of two types, intestinal type and diffuse type, based on Lawrence classification, which I will discuss in further slides. In the intestinal type of gastric carcinoma, we can see the molecular changes are APC gene mutation, which activates WNT signaling pathway. The next step is beta catenin mutation. It increases cell proliferation. TP53 mutation, loss of cell cycle control. Further, the microsatellite instability is seen due to defective DNA mismatch repair. HER2 amplification in some tumors, which promotes the growth. In diffuse type of gastric carcinoma, the main molecular defect is CDH1 gene mutation, which encodes E-cadherin. So therefore there is a loss of E-cadherin. This is the Lawrence classification, which I had told. Lawrence classification of gastric carcinoma is divided into two types, intestinal type and diffuse type. The intestinal type usually is seen in older adults, whereas diffuse type is seen in younger patients. Usually males are more affected by intestinal type of carcinoma, whereas diffuse type is equal in both sexes. Intestinal type is associated with intestinal metaplasia, whereas diffuse type is not associated. Diffuse type has poorly cohesive cells, signet ring cells, and lineatis plastica. Molecular defect, as I already told, there is mutation in APC, beta catenin, and TP53 in intestinal type, whereas CDH1, that is E-cadherin mutation in diffuse type. Intestinal type has a relatively better prognosis compared to diffuse type. Risk factors for intestinal type are H. pylori infection, chronic gastritis, intestinal metaplasia, dietary factors, whereas risk factors for diffuse type are genetic mutation less related to H. pylori. Gross morphology. The intestinal type shows exophytic mass. It shows bulky ulcerative or fungating lesions. It is usually found in lesser curvature of the antrum and pylorus. Gross morphology of diffuse type is there is diffuse thickening of stomach wall. It is also called as lineatis plastica or leather bottle stomach. Microscopy of gastric carcinoma. The intestinal type has well formed glands. There is mucin production in the intestinal type and desmoplastic stroma. In diffuse type, we can see poorly cohesive signet ring cells. There is little or no gland formation. There is intracytoplasmic mucin and diffuse infiltration of wall. Spread. There is direct spread, that is to duodenum and esophagus. Lymphatic spread through Virchow node, that is left supraclavicular lymph node. Hematogenous spread to liver and lungs. And transcoelomic spread, that is Krukenberg's tumor to ovaries, sister Mary Joseph nodule. Clinical features that can be seen in gastric carcinoma are weight loss, anorexia, epigastric pain, vomiting, occult blood loss, and iron deficiency anemia. The next topic is adenocarcinoma of colon. Introduction. Most common malignant tumor of colon. Adenocarcinoma of colon is most common malignant tumor of colon. It usually arises from adenomatous polyps. Risk factors of adenocarcinoma of colon are dietary risk factors such as low fiber diet, high animal fat, and red meat. Genetic risk factors are familial adenomatous polyposis and Lynch syndrome. Inflammatory risk factors are ulcerative colitis and Crohn's disease, also termed as inflammatory bowel disease. The molecular pathogenesis. There are two pathways in which adenocarcinoma of colon takes place. First one is APC or beta catenin pathway. It is due to chromosomal instability. There is normal mucosa where which APC mutations take place, which is followed by adenoma, which is further followed by KRAS mutation, which leads to TP53 mutation following carcinoma. It is also known as adenoma and carcinoma sequence. The other pathway is microsatellite instability pathway, where there is DNA mismatch repair defects and MLH1 MSH2 mutations. This is the diagram of pathogenesis of the adenocarcinoma of colon. It is also known as adenoma carcinoma sequence. Here the mucosa are at risk. There is loss or mutation of APC locus on chromosome 5q, which leads to hyperplasia. Cells multiply more than normal in hyperplasia. Tissue is still not cancerous, but the risk has increased. The risk of cancer has increased. There is a loss of DNA methylation, mutation of RAS gene on chromosome 12p, loss or deletion of tumor suppressor on 18q, which causes adenoma and dysplasia. Cells shows dysplasia, meaning they look abnormal under the microscope. Further, adenoma is still benign, but it is a pre-cancerous lesion. Then there is loss of p53 gene on chromosome 17p. There is cancer development, that is carcinoma in situ. Cells become cancerous but are limited to the mucosa. They have not invaded through the basement membrane. Further, there is formation of the invasive carcinoma. Cancer cells break through the basement membrane and invade the submucosa, muscularis propria and beyond. This stage can spread to lymph nodes and distant organs. That is known as metastasis, the spread of cancers. The total genetic changes are loss of p53 gene. That is p53 gene is called as guardian of the genome. This is the last genetic change that takes place. Gross morphology of right-sided tumors are exophytic polypoid fungating masses. They rarely obstruct the flow in the GIT, whereas left-sided tumors occurs as annular lesions. They appear as napkin ring or apple core appearance. They cause obstruction. Here we can see the fungating polypoid carcinoma in the right-sided tumors. This is the gross appearance of right-sided growth. Here we can see the annular lesions. This is known as napkin ring configuration. They obstruct the GIT flow, whereas here there is no obstruction. These in the left-sided growth, the growth are like the ring-like structures, so it is called as annular lesions. Microscopy. It is distinguished into well differentiated, moderately differentiated, poorly differentiated. In the well differentiated forms, the gland forming malignant cells are seen, and there is mucin secretion. In the moderately differentiated, there is irregular glands, whereas in the poorly differentiated carcinoma, you can see sheets of cells, little gland formation. Other features are desmoplastic stroma, necrosis, and invasive growth. Here we can see the histological diagrams of this is the well differentiated carcinoma, and this is the poorly differentiated carcinoma, and this is the mucinous adenocarcinoma with the signet rings cells and extracellular mucin pools. These are the signet ring cells. Clinical features that we can see in the adenocarcinoma of colon are occult bleeding or melena. It is the black discoloration, black colored stools that is caused due to bleeding. Also, change in the bowel habits can be seen more often in the left-sided growth. Loss of weight or cachexia also can be seen in adenocarcinoma of colon. Loss of appetite or anorexia can be seen. Anemia, weakness, and malaise also can be seen. Obstruction and hemorrhage are the most common complications of adenocarcinoma of colon. Spread. Locally, it spreads to the adjacent organs such as small intestine, rectum, and other nearby organs. The lymphatic spread is to the regional lymph nodes. Hematogenous spread occurs and cancer may metastasize to liver, lungs, and peritoneal tissues. Summary of today's video. Features: etiology of peptic ulcer is Helicobacter pylori mainly and NSAIDs. It is most common causes. In gastric carcinoma, it can be due to Helicobacter pylori mostly and smoking and the diet habits. Adenocarcinoma of colon is caused due to diets, polyps, and FAP and Lynch syndrome. Gross features of peptic ulcer are punched out ulcers, whereas gastric carcinoma or ulcerative or rhinitis plastica. Adenocarcinoma of colon has gross features of polypoid or napkin ring. Peptic ulcer is microscopy has 4 layers, that is superficial exudative zone, granulation tissue, and fibrous scar, as well as inflammatory cells formation. The microscopy of gastric carcinoma are glands or mucin glands or signet ring cells, whereas adenocarcinoma of colon microscopy we can see malignant glands with desmoplasia. Complications of peptic ulcer are bleeding, perforations, whereas gastric carcinoma are metastasis. Adenocarcinoma of colon obstructs the flow and it also causes metastasis. Common metastasis can be peptic ulcer, there is no metastasis. In gastric carcinoma, it metastasizes through versus node and to ovary. Adenocarcinoma of colon usually metastasizes to liver. This is it. Thank you one and all for watching the whole video you have watched. As our legend said, Sarve Janaha Sukhino Bhavantu. Live in peace. Thank you again.